My fellow young surgeons, you will definitely like it. Phaco in hard cataract has its own risks: stress on the bag, leading to increased chances of zonular dialysis, leathery fibers, a forceful chop, increased risk of PCR, endothelial cell loss, and wound burn. So here is a video which shows how to analyze and strategize the management of a hard cataract with good outcomes. A case of a hard brown brunescent cataract, making of the two side ports, followed by intracameral preservative-free lignocaine 2% and dispersive viscoelastic to coat the endothelium. We initiate the capsulorhexis. In dense cataract, the rhexis should be bigger in size, which should be around 5.5 mm in size owing to the intraoperative manipulation, followed by creation of a 2.8 mm triplanar main port incision, which is then followed by a gentle hydrodissection with a small amount of fluid. We then follow a soft shell technique. Dispersive OVD is above the cohesive OVD. Posterior plate is difficult to crack owing to the hardness of the leathery fibers on the posterior aspect. The central trench for about 70% of depth is made so that it is easier to break the core, as the core is the hardest and the densest part of the nucleus. Once we have a 70% of the depth, then we can change to Phaco 2, where we can go for a direct chop and separate the two heminuclei. Once the two heminuclei are there, then we rotate the nucleus very gently, followed by creation of 4 nuclear fragments. Once 4 nuclear fragments are created, then we eat each fragment step by step, slowly and slowly, with the controlled maneuvers. It is a good technique to refill the anterior chamber with OVD, both dispersive as well as cohesive, so as to maintain the chamber and coat the endothelium to prevent the endothelial cell loss. When we are eating the nucleus, we make sure that the dialer or the chopper is above piece which is being phacoemulsified, so that it decreases the chatter. Once we are approaching the last piece, we have to be very careful of the parameters. Why? Because the posterior capsule in hard cataract is very thin and it can come in the vicinity of the phaco probe, which can result in a PCR. So we take out the chopper when we are eating the last fragment of the nuclear matter, so as to have a stable anterior chamber. Then it is followed by irrigation and aspiration. We find that some of the lens fibers are still attached on the posterior capsule, so we go ahead with the posterior capsule polishing with the help of BSS. Once this is done, the IOL is implanted in the bag and entire viscoelastic is taken out with the help of irrigation and aspiration. You can notice that the incisions are not even hydrated, there is no wound burn. So with these steps, we can easily have a clear cornea on the next day. As a result, first post-operative day, a clear cornea and a happy patient. I hope you enjoyed the video and did find it learning. Thank you.